Right, let's speak now to the Free Market Foundation. Michael Settas is joining us, saying this bill is politically motivated, unaffordable, incapable of delivering better health outcomes and will infringe on numerous constitutional rights. And one of these is the right of South Africans to access health care of their choice. The Foundation's Health Policy Unit Chairman, Michael Settas, joining us for that. Michael, good to have you. And thank you very much for coming on. You're already preparing a legal challenge to this. What is that legal angle that you're going to be taking in challenging the NHI Bill?
Yeah, well, thank you very much. I mean, there are numerous factors on it. I mean, I think probably the most obvious, which has been touted by the private sector, is Section 33, which is the denial of citizens who can afford private care to take out their own private care. The aspects around legality in terms of sorry, did the sound disappear there?
Yeah, we still hear you. We still hear you. Go ahead. Yeah.
Yeah. So now I apologize.
Michael, you still there?
Yeah, sorry, I seem to be having sound problems here. Yeah, so if you can hear me, I'm still saying that Section 33 is the biggest aspect around for the private sector in terms of denying people to access private care. So I think that's the key issue around lack of constitutionality. There's some issues around the legal aspects around the governance framework within the NHI. There's not a separation of powers, which is a big problem. So there's a concentration of power, specifically in the post that holds for the Minister of Health. And that's a key issue around fighting against corruption, which the Zondo Commission specifically spoke out against. That was a key issue around separating the executive from the public service administration. So those I think are some of the key issues around where the constitutionality lies. And I think those are the actions that, if we do take them, will be there, but I think many other stakeholders as well.
So, I mean, the department saying that this is only one aspect of a broader, I suppose, a program of improving the system, and it's not even at a point where it is fully, what can I say, fully finalized as to how it will be managed. And they find some of these objections to be quite bizarre, because it's still in the first phase of implementation, and some of the difficult questions and issues that would need to be put in place would still need the president, for example, to put a date on them on when they would need to be finalized. So those issues are still being able to be addressed within the implementation phases of the NHI.
Yeah, I think, the aspect is that the bill that should now become the NHI Act, if President signs it tomorrow, which we presume he will, obviously, given the announcement. Those aspects, the key aspects that are in what will be the NHI Act are there. I mean, we're not, those are not going to change in terms of a later promulgation. And the aspects specifically are around denial of access for people who can't afford it, and specifically the governance. I think those are really the key issues around it. And those are not going to change in terms of what President Ramaphosa, or whoever is president at a later stage, may promulgate or pass through regulation.
So they are saying that there is, of course, this need that private sector and public sector and provincial hospitals in particular should actually be calling for the NHI, because of just the inequity in how government subsidies are being spent. For example, where you'd see in a public sector space, where you've got more of the patients coming in, and one patient there, they say if you look at it and you break it down into rands and cents and how much is being spent, it will come down to 5,200 being spent on one patient, where when you look at the amount being spent on the private sector, that jumps to 30,000 being spent on a patient, to say that should be something that concerns both the public and the private sector. To say it's quite a strange way of government money being spent and should be spent a little bit better.
But the problem with that statement, and I appreciate that has been touted around routinely, is that the 30,000 is not government money. It's private sector money. It's people spending after-tax private money on themselves. And I accept that there's an inequity between it, but it's not an inequitable spend from government. You know, the government spend is equitable across all citizens. The essence of the medical tax credit, which medical scheme members get through a medical tax rebate, is equivalent roughly to what the spend is in the public sector on a per capita basis. So that creates the equity. The issue around that quote, which obviously has come from government on a regular basis, is that they're conflating private sector funds against public sector funds. And I mean, you simply can't do that. I mean, it's not to say that, like if you wanted to compare or take every function that government provides and then take what's spent in private, you would obviously always have more being spent in private because of people spending money on their own selves. And so it's a spurious argument. I mean, and it can't be equated because there's not government money that's being spent. And government has continually conflated this issue in this policy process to say that the money being spent in the private sector is if it's government money that's being spent, which it just simply isn't.
So you have the view that, for example, the government saying that part of what is being challenged is what will be spent by NHI or what will be funded by NHI and what will be funded by the private sector, that nothing is going to stop private schemes from funding particular procedures that are not funded by the NHI. I mean, if private patients want to pay for particular procedures and particular products that are not within the NHI, they're still more than welcome to do so.
Yeah, that's correct. But I mean, the point is what they're saying is that for those procedures that the NHI will cover, that they cannot access those in the private sector. So what they're actually creating is a split system, a two-tiered system, in saying that for services that the NHI covers, you have to get them from NHI. But if NHI doesn't cover them, then you have to go to the medical scheme. I mean, technically, that's a disastrous process in which to follow. The aspect around people accessing private cover as they do now is that they take themselves completely out of the public system. So in other words, they cost the government nothing. So the way in which the NHI is proposing now is they want to pull everybody into NHI. So pull all the liability onto the NHI, including those people who are quite willing to spend their own private money on themselves outside of NHI. It makes no economic sense whatsoever. And given our fiscal position, I mean, it makes absolutely no sense for the government to take on the liability of everyone's healthcare, including those who are willing and able to pay for it themselves.
Yeah. So, I mean, the argument then therefore is that you could have made that submission, but it's been 20 years of consultation, it's been a white paper, and it has gone back and forth. And there have been other submissions that were made, and the majority of those submissions says, but that's precisely what we would like to see, where there is equal access to everybody. And it cannot be that now you would want to challenge that in court just because your own submissions would not have been recognized.
No, I get that aspect of what they're saying, but the point is what they're trying to emphasize or trying to allude to is that they can replace what private sector is currently spending on medical scheme contributions with additional taxes. And that's just simply not going to happen. It's impossible. They won't be able to raise it. I mean, we're already at the point of being, one of the highest tax countries in the world. And now we're going to move to a point of adding even more to that. It's not a viable policy. It simply cannot work. I mean, given the fact that even Treasury have come out on this quite emphatically, the finance minister last year in October, and more recently last week at the Board of Healthcare Funders, one of the senior Treasury officials just said there's just no scope to raise these additional taxes to achieve that.
So their view that, Dr. Nicholas Cripps likes to say this, says the author of the heavy tax burden and the raising of taxes is alarmist. Can they please provide the department and the public with where they are getting this calculation of more taxes?
Well, it was in the green paper and both white papers. I mean, it was there the intention is to raise around about, I think it's 3.2% of GDP in new additional NHI taxes. It's there. I mean, you can't now say that it's not there. That's been the policy principle since the green paper, which came out in 2011.
So he says there is going to be a spending within the already allocated budget framework. There is nothing more that is going to be spent.
This is the point that I made just now. He's taking what is spent in the medical scheme sector and saying that can be included as if it's public sector budget. It's not. It just simply isn't. So the argument is that instead of spending on your medical aid, we'll raise additional NHI taxes and it'll be equivalent.
Yeah.
But it simply isn't.
No.
You're not going to get.
Of course. Yeah. And he concedes to that. He says medical aid scheme contributions do not belong to the state, but once the state provides funding for the purchase of a service for a taxpayer, it has a right and an obligation to collect the required fund to pay for the service.
Yeah, but I mean, once they've diluted across the entire population, it won't be the equivalent. Okay, so whilst you might argue that then that's not equitable, but again, I come back to the point that whatever people spend in the private sector is their own money versus what the state spends on people is public sector money. The issue here that you have is that if we go to the current taxpayers, who are the majority of medical scheme contributors as well, there's a massive overlap between those two. And you take away their right to finance their own healthcare, you're going to see a loss of taxpayers, shrinking of the already thinning tax base. So you might even get to a point of having more money. You might even have less than what you have now in terms of public sector health financing. So and the feasibilities around understanding that as to what will happen to the tax base if you impose such massive amounts of new taxes upon the tax base. It hasn't been done, so there's no understanding of what's going to happen if these kind of taxes are imposed.
And do you see this, changing at least how healthcare is provided in the interim while you're still in the court? Because the department believes that, yes, you can take it and challenge it in court, but the National Health Act is already in place. The fact that you're challenging NHI doesn't mean they cannot be implementing some of these things already.
No, that's true. I mean, obviously they could carry on the government in terms of implementing as they wish or intend to. But I mean, the funding is just simply not there. I mean, as I said earlier, both the finance minister and senior treasury officials have said that there's no ways that they can raise new taxes on this. But I think that comes to an important point that we need to maybe bring to the fore here, which it's been kind of a red herring around this entire policy, is that it's almost as if that the Department of Health currently has no financing. It can't be anything but it simply doesn't have any money. But I mean, if we look at how South Africa compares in terms of its public sector per capita budget against other peer countries, the upper middle income classifications, we're very much in line with what they spend. The money's there. The problem we have is the outcomes are terrible. Outcomes are awful compared to those other countries. So what is happening is we're not getting the kind of outcomes for the same equivalent amount of money that's being spent in other countries for what we are spending. So the real issue that's not been addressed here is what the problems are in the public sector that prevent proper healthcare from being delivered. And the real issues are governance failings that are prevalent across almost the entire public sector. Poor management. We just simply have a failing system, then that's not being addressed. And the NHI is not going to address that either. But that doesn't get spoken of. It's as if the NHI is going to come along and fix all these problems. But if we overlay the NHI on top of the current public sector, which is dysfunctional, it's not going to improve.
Michael, appreciate your time. Thanks so much for coming on. Michael Settas is the chairman of the Health Policy Unit of the Free Market Foundation, and they have views and thoughts on the signing of the NHI Bill. Right, top of the hour, we'll bring you your headlines. Stay with us.